I know that we're starting off with some acute stroke management. A couple years ago, I gave a talk at this meeting, and I said, Glenn, what would you like me to talk about? And he said, how about stroke? And I said, well, that's fitting. I'm a vascular neurologist. I said, what part of stroke would you like me to talk about? And he said, all of it. And I said, wow, I don't know if anyone attended 2 years ago. I gave a talk, and I tried to go through acute therapy and secondary prevention and everything all together. And I'll be honest with you, it was a lot to digest in that brief amount of time. It was the first year that we were virtual, and we allowed some questions to come back and forth, and I think I ended up answering 150 to 200 questions after the meeting. So I said, this year, we need to focus this down, I think, a little bit more. And I think something that some people are, the secondary prevention, I think, is more straightforward. Sometimes the acute therapies and the things that make people nervous, they change rapidly, and they're changing all the time. And so I thought that doing an acute kind of stroke update made the most sense for this talk. So I hope it's useful. I'll go over kind of what we're going to be talking about here in a second. Some of the objectives, I have no disclosures. Some of the objectives that I've put here just to give you an overview of where we're going. We'll talk about stroke and definitions. I know that everybody uses definitions correctly in the field of neurology, but you will see that many of your colleagues will not. So I'd like to go over some definitions of what we're talking about to make sure we're all on the same page. Just discuss briefly some common etiologies, which again will not be a surprise to anybody, and then really go over some of the literature, and this will be a guideline-directed talk. So most of this talk will come from the guidelines that have been put out by the AHA and the American Stroke Association. And then I thought that it would be useful also to go over the new ICH guidelines that have just come out. So I figured that we could spend a little bit of time on that and really highlight some of the new things in the guidelines for ICH. It's been the first time since the guidelines have been updated since 2015. So we have some new things to discuss. And then we'll talk about some mobile stroke changes and updates and some literature out on mobile stroke. I might be a little bit biased being the director of our mobile stroke unit at the Cleveland Clinic, but I'll give you some information about what we're doing from a pre-hospital standpoint as well. So with that being said, let's get started. I know I'm up against the clock, so we'll keep things rolling. So ischemic stroke, I think everybody is pretty familiar with what we mean whenever we talk about ischemic stroke. Lack of loss of blood flow to the brain due to either narrowing or blockage of one of the arteries that's affected. As a basic overview, TIA, this is the one that I get asked about the most. So what is the definition of TIA? The time definition is falling more and more out of favor. I think a lot of us favor the tissue diagnosis of TIA. So any sort of sudden transient neurofunction caused by focal brain, spinal cord, or retinal ischemia without acute infarct. So really, if you're doing a tissue-based, you need an MRI to be able to show that. And the old time-based definition, it always included this 24 hours, which is fairly antiquated at this point in time, which I'm sure a lot of you know. So typically less than 60 minutes. I mean, the vast majority should definitely be less than 24, but it's very rare that we see like a TIA that's 20 hours in. There has been a lot of literature, I'm sure that some of you have seen out about TIAs right now and what we should be calling these, and whether or not there was a recent editorial about should we go back to mini stroke. And I think a lot of us were like, oh my gosh, no, please, let's not go back there. But if you read about why and the microvascular changes that may take place even with a TIA, it does make some sense. So just so that you know that there are some new thoughts out about TIA, you will see this used quite frequently. And then ICH, for the purpose of this talk, whenever I refer to ICH, we're going to talk about parenchymal ICH. And then subarach and subdural, can also be intracranial, so you'll see ICH sometimes there too. But for my talk, we're going to be talking about directly into the brain tissue. Just so that you know, we're going to be talking about modified Rankin quite a bit. For those of you who don't know, I put it up here. It's basically a functional outcome scale that goes from 0 to 6, with 0 being the best, no symptoms, and 6 meaning death. A lot of our stroke literature, as you're all familiar with, use modified Rankin for functional outcomes. And there's some pros and cons to that, but we won't get into that for this talk. Abbreviations, just so whenever I'm going through here, everybody knows what I'm talking about. We're all on the same page. I put some of these up. I think most of them are pretty self-explanatory. EBT I use for endovascular treatment. So that's something to point out. SICH, symptomatic ICH, and then the rest of them I think most of us are probably familiar with. But here's a slide for you all to just glance at quickly so whenever we're flying through the rest of this. So with that being said, Stroke signs and symptoms. So a couple things that I like to point out. I think most of us are familiar with stroke signs and symptoms. The BFAST model has existed for some time, and I think it's a fairly good one just to educate patients with. This is what I use all the time. I put this on after visit summaries. I think it's really important that we focus on these ones, but there are a couple things, if we move along from this, that I think are important to mention also. Whenever we talk about stroke, again, stroke is a combination of different types of stroke. So ischemic stroke and hemorrhagic stroke. I think a sudden worst headache of someone's life should always be taken seriously and treated as a stroke sign. Hemisensory loss technically isn't included in BFAST, and then acute vestibular syndrome. So this is the one, and you'll see I put +1. So what do I mean by +1? This is if someone comes in with an acute vertigo or acute dizzy spell. If we're concerned about posterior circulation stroke, there should be something else. So I think, we do HINTS tests and based off of exam, but just based off of history alone, if you have someone who comes in, they're acutely vertiginous, they should have one other posterior circulation finding. So whether that's dysarthria, diplopia, dysphagia, any gaze palsies, there should be something else going on that would indicate maybe there's something posterior circulation. So just having an acute vestibular syndrome is not very specific for posterior circulation stroke, as many of you are aware, but if you get one of those other pieces of the history, your antenna should go up a little bit faster. And then etiologies of ischemic stroke. So we have been using the TOAST criteria for quite a long time. So 1993 is when the TOAST criteria came out, and everybody refers to TOAST, which stood for the Trial of Organization 10172 for the acute stroke treatment. So this has been around for a very long time, and they kind of classified this based off of what's most likely to cause a stroke to least likely. Now that has changed somewhat over the years, and this has been revised a couple times, the TOAST criteria. The biggest revision was from a study that looked, it was called SSS TOAST, and basically what this did is it took the TOAST classification system, and it also allotted a possible, probable, or definite. So it gives you a little bit more of what do we think is really going on and how certain are we about that. But just to throw out some of these things whenever we refer to large artery athero, that one's pretty common to most people. Can include carotid, that's what we think about most often, but also intracranial disease. Cardioembolism, obviously a lot of things can cause cardioembolism, not just atrial fibrillation, which is what we typically think of. Small vessel occlusion, again, a very, very common cause of stroke due to many vascular risk factors. And then whenever we get into 4 and 5, I see these used sometimes incorrectly, so I just wanted to highlight them. So stroke of other determined etiology. This means that you know what happened, but it's not fitting into one of the first 3 TOAST classifications. So what would be that? Arterial dissections, hypercoagulable states, vasculitis, an iatrogenic stroke, et cetera, et cetera. So that would be classified as a stroke of other determined etiology. And then undetermined etiology doesn't always just mean you have no idea what's going on. Sometimes that's what it means, but not always. If you think that 2 possibilities could be likely, then that can also fall under undetermined etiology. And oftentimes that happens. If you don't have a full evaluation yet, or if the evaluation is negative, if it's a true cryptogenic stroke, then certainly these patients will fall under this category. So if we get into the bulk of the talk, so some acute stroke care updates. This is kind of how I have outlined this. We'll talk about IV thrombolysis to start, and then endovascular therapy, and then ICH. So I guess hold on to your seats, and we'll go through this pretty quickly. So time of onset or last known well. This is always the most important thing that we need. I can't tell you how many times I do a telestroke, or I go to the emergency department, or I get consulted in the hospital for last known well, and it's oftentimes incorrect. So last known well, if the symptoms were witnessed, obviously that is your time of last known well, when the symptoms were witnessed. Oftentimes symptoms are not witnessed while they're happening. If that's the case, it has to be the last time that someone was seen at baseline. So it's not whenever, someone goes to their parents' house and finds mom or dad or grandma, with symptoms, and the last time anyone's seen them was 2 days ago. The time that they were found is not the last known well. So we just need to be really, really clear about this, because this directs everything that we're going to do for that patient from that point on. And there are a lot of good reasons why we use this. So last seen normal. So So if someone went to bed, the classic story is they went to bed, they woke up with symptoms. Now, oftentimes I will say, are you sure that they woke up and they were normal? Yes, they were normal. They sat up in bed, they did not feel anything. And I'm like, well, this is aphasia. Did they talk to anybody? Did anything happen? And oftentimes, the more that you dig, the more that you find out that something was off. Well, they went to the bathroom, and on the way to the bathroom, they fell. So whenever they got out of bed, they were normal, and then on the way to the bathroom, they fell. Chances are they woke up with some symptoms, and it manifested itself whenever they started being more functional that morning. You can get pretty creative with last known well, so I put some of the ones that we've used. I had a patient say, well, I don't know what time, but I noticed that something was off whenever I started watching Jimmy Fallon. So you know what time Jimmy Fallon was on the night before. We have actually had on our mobile stroke unit, there was an elderly woman who lived by herself, and her kids had not heard from her, and so they went to check on her, and no one knew. She was found down. No one knew what time it happened. Last known well would have been 2 days ago. Well, she had a Ring camera, and the family had actually set up a Ring inside so that they could keep an eye on her, and they gave us access to actually log in, look at the video, and we could actually